name is Laura Carroll, and I am the president of your Colorado Medical Services Board. Welcome to our October 2025 meeting. With this, I will call the meeting to order. Mr. Sykes, can you please help me with roll call?
Certainly. This is Chris Sykes. Laura Carroll.
Present. Good morning.
J.K. Costello.
Present.
Morgan Honey. Amanda Jaslinski.
I'm sorry, I'm looking for my excuse list. I don't have it in front of me. My apologies. There we go. Okay, I don't have anybody showing excuse, Mr. Sykes. Is that correct?
That is, I believe, this is Chris Sykes. I believe Morgan Honey got called into multiple meetings.
Okay,
And so
and I know Mr. McLaughlin has been an excuse now too.
William Kennard.
Present.
Barry Martin.
Present.
Cassandra Littler.
Present.
James McLaughlin.
Excused.
Christina Mulkey.
Here.
David Pump.
I am here.
President, we have a quorum.
That is lovely. Before we carry on, we're going to have, are you going to be speaking with us this morning, Rachel?
So this is Rachel Entricken with the department. Chris, can you check and see if Adele Flores Brennan has joined us?
Do not see, this is Chris Sykes. I do not see Adela Flores Brennan on the call yet.
Madam President, may I?
Please. Thank you, Rachel.
Thank you. I'm Rachel Entricken. I am the legal division director for the department. It's wonderful to be here in Woodland Park with everybody. And it's lovely to see folks in person too. Thank you for joining us today. I have a couple of short remarks. The first is just for the board. I wanted to let you all know, and this is a message that you've heard before. I wanted to make sure that we are keeping top of mind, that we are continuing to work very hard on truing up our budget and making sure that Colorado, which requires a balanced budget, has that. We have a North Star that we're following to make sure that any reductions that we need to make are as limited as possible and doing as little disruption as possible to the services that our members need.
Progress.
So I just want to say, put into context that over the next several months, the board will see mostly emergency rules coming before you. We will do our very best to let you know in advance if there will be an emergency rule, but some of them are just that. They're an emergency, they come up quickly. But our commitment as the department is to really make sure that the rules that you get are high quality and understandable, and we do as much engagement with the public before we present them to the board for consideration. Which leads us to my second point, which is that on document 9, which is our pediatric behavioral therapy rule, we heard a lot from a lot of people who had concerns about the PDT rule as written. And so I'm looking at our visitors because I really thank you for coming today. We made the difficult decision yesterday of taking that rule off of the agenda. We heard you loud and clear that we need to do some additional work and some additional stakeholder. And so we think it's better to take the rule off the agenda this month. We'll work internally to decide when it will come back. It will likely be next month after we've had some additional conversations with our stakeholders.
Thank you, Rachel.
Thank you, Madam President.
And with that, this is Laura Carroll. With that, I also wanted to take a moment to say thank you to our communities. I love that we have a space where you can raise your voice and be heard. It is my favorite part. Thank you. Thank you to everybody who's watching, who sent letters, who signed up for testimony, who showed up in person. This is what we want our MSB to look like. Thank you very much. We've heard you. They're going to make this rule better and try again. With that, I also want to have a conversation about what we're going to do with public forum later on as we get to that. Because this rule is not being presented, because we are planning to have the department go back and engage in the appropriate stakeholder feedback before they represent this rule to us. We are going to ask that public comment not include the issues on this rule that we have pulled. First of all, that is policy for us. And second of all of us have traveled to here, some of us almost 6 hours. And while we love hearing from everybody, and I'm here to tell all of you, we read every single letter. Every single one of us read every single letter. We want to make sure we stay focused on our topics at hand today. And when that rule comes back, we're going to make sure you all know it so that you can be here and we can have the appropriate feedback as necessary. I want to thank everybody for stepping up into this rule to make sure we get it right. And with that, I will bring our official public announcements. The date and location of the next Medical Services Board meeting is scheduled to be held Friday, November 14th, 2025, beginning at 9 a.m. virtually and in person at 303 East 17th Avenue, Suite 1100, Denver, Colorado 80203. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Please identify yourself when speaking comments. They are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input in alignment with the department's mission and in the best interest of Coloradans. There is testimony sign up for the open forum and for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Public comment will be limited to 3 minutes, and at the end of 3 minutes, your time will be up and we will move on to the next individual signed up for testimony. Thank you very much. And then did we have anything from Adela this morning? She had to pass this morning, is that correct?
Madam President, this is Rachel Entrican. Yes, Adela was pulled into an emergency meeting, so.
Did we want to hold space at the end to do department announcements, or does she feel? She's good. Adela, like a ray of light. Good morning.
Good morning. Can you guys hear me?
You can. Thank you for joining us. I know you're getting pulled all over the place today.
Yes, it's been a lot lately. Good morning, everyone. Adela Flores Brennan, Medicaid Director with the department. Apologies for running late. I guess that goes to some of our announcements. We have a lot coming at us these days from our federal partners, and my meeting this morning was all about one of several inquiries that we are dealing with regarding information around people who are accessing emergency Medicaid services. So a lot of additional work pulling data and information for the U.S. House Oversight Committee, as well as our friends at CMS. In addition to that, I think we wanted to just reconfirm some things that we've already mentioned before, and that is that with the passage of HR 1 back in July, it really has intensified what was already a pretty significant budget challenge. And so while we were already facing state budget pressures, we are now under additional pressure because of the impact of HR 1. Both because it had an immediate impact on the amount of revenue we are collecting at the state level, but also because it is going to require us to invest in things that we had not planned on investing in, like new systems and operations to make some changes to the Medicaid program. So as a result of that, the governor did call a special session, as you're aware, and then took some additional steps in issuing an executive order to direct that we make some budget reductions for the current fiscal year. I will say that we should also be prepared for additional budget reductions as we move forward because this is not just a one-time budget challenge. So I appreciate all of your patience and understanding. I know that, as we've tried to confront some of these issues and to help blunt some of the enormous cost increases that we're seeing in some of our benefits, we've been trying to move really quickly to move some rules forward. As you've already noted, we've pulled one down to give us a little bit more time. We're going to work closely with our stakeholders to help to refine that a little bit more so that it's in a better place for you all next month. We are trying to really stick to our 6 guiding principles around how we can control costs in the Medicaid program with, hopefully without using too blunt an instrument, but rather doing so in a targeted and sustainable way. So in doing that, we are looking at what are the drivers of trend, and that is why you'll see some of the things that are coming your way through rulemaking, because we've noticed significant drivers in trend. We are trying to, despite all the changes at the federal level, we continue to try and maximize our federal funding, and we're looking for opportunities to do that and have identified a few that we'll be exploring. We do want to continue to invest in Coloradans and make reasonable Medicaid adjustments as we identify them. We will reassess new policies. So new policies that through legislation or other directives that we have been asked to put in place, we may need to pause or halt those implementations in an effort to control our trend moving forward. And then, of course, we'll exercise caution as we think about new programs and new increases. We continue to focus on North Star, which is mitigating inappropriate coverage loss, especially as we need to implement all of these new federal changes. And we want to avoid drastic cuts. So we're trying to be, again, as targeted as possible as we move forward. And in the same time, as I mentioned, we're having a lot of other interactions with our federal partners as they have more inquiries about specific programs that we're running. And then we are also preparing already, of course, we'll have our budget rollout in November, and then, of course, legislative session coming in January. So, and it all starts over again. So happy to provide any additional updates or answer any questions if you all have them.
Thank you, Adela. Do we have any questions from the board? Not hearing any, Adela. We so appreciate you taking the time today. We're having some minor technical problems in the room, but I can see you and I can hear you.
This is Chris Sykes. Yes, the technology we're using is trying to connect to an Apple TV, and that's what.
Oh, the joys of travel. So I am definitely monitoring on a separate PC also, team, so there's always at least one screen up somewhere. All right, and I did get word from IT back in Denver that they can hear us and see us perfectly, and that's the part that we care about the most. Very good. All righty then. With that, then let's go ahead and approve the minutes for the September meeting. May I have a motion to approve those minutes, please?
Madam Chair, this is David Pump. I'm happy to do so.
Thank you, Mr. Pump. Go ahead.
I motion that we accept the minutes.
Thank you. May I have a second, please? Christina, second. Thank you, Christina. All in favor, please say aye. Aye.
Aye.
All opposed? Abstentions? Thank you, team. Minutes pass. And we are off to emergency adoptions. As we discussed, document 9 has been pulled from the agenda. So we are off to document 8, and we have Sarah Caslow presenting today. Sarah, are you with us?
I am with you this morning.
Good morning.
Good morning.
The floor is yours.
Okay. Good morning, members of the Medical Services Board. My name is Sarah Caslow, and I'm the Policy Specialist for the Laboratory Services Benefit. Today, I will be presenting MSB 25-08-26-A, Proposed Rule Revisions Related to Definitive Drug Testing. This is being run as an emergency rule because immediate implementation is necessary to begin containing inappropriate utilization and costs. Next slide, please. The department currently covers both presumptive and definitive drug testing when medically necessary. Presumptive tests such as urine analysis or UA provide quick initial screening to identify general drug types. On the other hand, definitive tests use advanced laboratory methods such as liquid chromatography mass spectrometry or gas chromatography mass spectrometry to confirm specific substances when results are unclear or require higher accuracy. Clinically, definitive testing is important in cases where precise identification is necessary. For example, in pain management programs, substance use treatment, or when unexpected drug test results need confirmation. These tests provide a highly reliable way for physicians to understand exactly what substances are in a patient's system. Because definitive testing is more complex and therefore expensive, it should be reserved for only when medically necessary. However, the department has observed a significant and continued increase in expenditures for these tests over the past several years. While these tests are important in some situations, they are often used more frequently than medically necessary. In some cases, large test panels are ordered routinely, regardless of clinical need. This has contributed to unnecessary costs and potential misuse. Next slide, please. The continued increase in expenditures for these tests is illustrated in this graph. Based on the expenditure trend for definitive drug tests, continuing without intervention will result in costs remaining above $5 million per month, or approximately $62 million annually, nearly double 2022 levels. By implementing a utilization limit on definitive drug testing, expenditures could be stabilized closer to $3.5 to $4 million per month, generating estimated annual savings of $12 to $14 million, with the potential for even greater reductions if spending is brought back toward 2022 levels. Next slide, please. To address this, the department is proposing to establish a coverage limit of 16 definitive drug tests per adult member per state fiscal year. This means we would only reimburse claims up to this limit and deny claims for testing that exceeds this limit. Children would not be subject to the same limit in order to ensure they can continue to access these services as needed. This policy is intended to strike a balance, preserving access to testing when it is clinically justified, while discouraging unnecessary or routine use. It will help ensure that drug testing is evidence-based, cost-effective, and aligned with best practices. The department conducted a review of other states' policies on definitive drug testing. There is a wide variation. For example, New York has a limit of 6 tests per year, while North Carolina allows up to 24. States such as Minnesota, Washington, and Oregon also impose restrictions. Based on this research, we believe that a limit of 16 tests per year represents a balanced approach for Colorado. Additionally, the department is conducting stakeholder engagement through surveys of medical and behavioral health providers for their input regarding the clinical utility of limiting drug testing to 16 tests per state fiscal year for adults. If the feedback received warrants an adjustment to this limit, it will be reflected as a revision at the final adoption of this rule. Next slide, please. In summary, this proposal maintains access to necessary testing while reducing wasteful spending. We brought this as an emergency rule to ensure that department resources are used responsibly and sustainably, and that adult members continue to receive care that is medically appropriate. Health First Colorado and the department are being harmed financially by inappropriate billing for definitive drug testing services. By limiting these tests to no more than 16 units per state fiscal year for adult members, the department aims to ensure drug testing is appropriate, evidence-based, and cost-effective. This will protect program integrity and sustainability. Additionally, given the current budget crisis and to preserve the integrity of Health First Colorado, it is critical that funds only be used for medically necessary services. Therefore, to preserve public health, safety, and welfare for Health First Colorado members by protecting the department's budget, it is imperatively necessary to bring this proposed rule revision as an emergency to stop the inappropriate spending within the laboratory benefits. If I can answer any questions or concerns, please let me know. And thank you for your time.
Thank you, Sarah. Do I have any questions from the board, Dr. Costello?
Yes, this is Dr. Costello. Ms. Caslow, thanks for the helpful graph. I found that really helpful. But I have some questions as to why this is an emergency rule to start with. I believe in 2015, the monthly expenditure for drug testing was about $50,000 a month. So expenditures have risen 100-fold in the last 10 years. So why is this an emergency?
I missed the last part of you cut out at the very last part of what you were saying. I missed that last tail end.
Oh, my question is, why is this an emergency if it's risen 100-fold over the last 10 years?
I'm sorry, Sarah, can you hear us?
Yes, it has to do with the current budget crisis. And just let me get there really quick. Hold on.
Madam Chair.
Yes, Dr. Kennard.
Can I fill the time while she has a chance to check things with a quick question or comment?
How do you feel about that, Dr. Costello? Is that good with you?
I have more, but I'll defer to that.
I think when I reviewed this, my only comment was, where you been? I mean, she had, and I love the graph, she had me at $5 million a month. I was stunned, absolutely stunned. And I think the question I would compliment that with was, where else can we find these things? Because that was shocking to me. And it was an emergency 5 years ago. When it went from 50,000 to $1 million. So now I think, that being said, I can't wait to support this rule change.
Appreciate that, Dr. Kennard.
Yeah, and just there has been a lot of fraud, waste, and abuse around the definitive drug testing with different providers. And that was brought to our attention in December of 2024. And it had to do with in 2022, the requirement for medical necessity documents to be submitted with the claim and was done away with that. It was no longer required that had to be a part of the claim. And then the other, there was no, because of the medical necessity, there was also no limitations. The limitations and restrictions were also lifted. And so there's 20 providers that the Colorado Attorney General is looking into that have been overutilizing and with fraud, waste, and abuse with these codes. And it's generally with G0483. That's the highest panel test, and it's also the most expensive. And because there's no limitations, providers are billing for that, utilizing that code for every time, every time they're doing definitive drug testing. And so that when that came into fruition, we've been working with the Attorney General to try to get limitations and medical necessity requirements also put back in place, and so that they can't continue just to bill for these tests.
Thank you, Sarah. Does that answer your question, Dr. Costello?
I fully agree that we should do this. I just don't understand why it's going through emergency rulemaking.
Gotcha.
And I understand the current budget crisis. If I may.
Please.
A lot of these groups own their drug testing. So there's no secret why they do drug testing all the time. It's because they own the lab. And so it's not only a fraud, waste, abuse, it's a conflict of interest, in my opinion. And we should take action on this, but I don't know that it needs to be through emergency rulemaking.
This is Laura Carroll. So to clarify, Dr. Costello, your primary question is why are we doing it as an emergency rule and not putting it through the appropriate processes of stakeholder engagement, et cetera? Sarah, are you able to answer that for Dr. Costello?
Why we're proposing this limit now is to address rising expenditures and unnecessary use. The goal is to maintain access while protecting program sustainability.
If I may, Madam President.
Please go ahead, Rachel.
This is Rachel Entrigan from the department. I guess just to add to what Sarah has already said, I think there are a few things that we now know, having been able to crunch the data and understand what's driving the trend here. A regular rule process typically takes about 5 to 6 months. Now that we know that there is waste or abuse happening, I'm not going to use the fraud word because that is something that needs to go through the process. But now that we know that there is waste and abuse, we have to act on it as quickly as possible. So it is both the fact that we are in a budget crisis like we haven't seen since the Great Recession. It is our responsibility to both protect state taxpayer dollars as quickly as possible, and also to make sure that we have good policy. So I recognize and appreciate the comments that you've made about why these changes weren't made sooner. A lot of the time, we get about 35 million claims a year. So we don't have a real person who is looking at all of those claims, and it takes trend analysis to come up with that data. And I think that certainly we are very committed to making sure that we increase the speed with which we can identify these trends. We now have new software and new tools that we can use to do that. So yes, there was absolutely a lag. And yes, we want to make sure that we catch these sooner. But the emergency is now. Absolutely, we don't want to keep spending good money now. And the regular rulemaking process is quite a bit lengthier. And frankly, this is one area where we always think stakeholder engagement is very, very important, always. In this case, however, I'm not sure what a stakeholder could tell us that would make us believe that someone should be getting definitive drug testing every week.
Agreed.
How did that feel, Dr. Costello?
I've got more, but maybe David can correct.
Well, I saw Dr. Martin's hand up first, but it seems to have fallen down, and I'm not sure if we just timed out on you or if your question got answered. Dr. Martin, how are we feeling?
Fine. I was wondering about, in most systems, 20% of the users account for 80% of the cost, and I was wondering who those users were in this case, and it sounds like we know who they are. And so, no other question.
Thank you, Dr. Martin. Mr. Pump, I see your hand.
Thank you very much. This is David. I really appreciate the conversation that we're having on 2 levels. One, from the department in regards to finding abuse and waste, and maybe even the F word on this piece. And I'm grateful for that, and I'm thankful that we are moving as soon as you get that data and understand that and taking action. So my first question on that particular piece is recognizing that who was doing that, and maybe the complications and maybe the F word and maybe conflict of interest and all that. The department's position, I'm understanding, is that there is an investigation that is happening on that particular issue, and it's not bygones are bygones, and we're moving forward. Is that correct?
Yes, that's correct.
All right. Does the Medical Service Board, this is a question of more operations, not the word I'm looking for, but more just a general question. Does the Medical Service Board get to hear the completion of that investigation because of this emergency rule?
I am not quite sure of that answer.
I mean, I think, thank you very much. This is
Sorry,
David
I
again.
need to jump in real quick. That was Sarah Caslow speaking. Sarah, if you could please identify yourself as speaking, that would make it, so I don't have to interrupt you. Thank you.
Okay, my name is Rick. Okay, I will do
Yeah.
that. Thank you.
This is David again. I super appreciate that the Medical Service Board is in this conversation, and I would personally love to hear conclusion at what point there is conclusion, because when we enact an emergency rule, it sounds like it is an emergency, which is super important. And to our earlier comments, I feel as if we use, or the department uses, emergency rule with some sort of metric that matrix that I don't really understand of why and how, and oh, this is an emergency and that's not an emergency, all that. And I think it might be a good idea, Madam Chair, if at some point maybe Jen provides just a quick primer for us on when and how emergency rules are used, just so we can understand that a little bit better.
I think that sounds like a terrific idea, Mr. Pump. This is Laura Carroll. And I think as on that same realm, I think we're all overdue for some of that definition level training session and stuff like that. So what I say to you, my friend, is stay tuned. Sarah, did you have any other response to what Mr. Pump had to say there?
This is Sarah Caslow talking. How would you like the conclusion? I mean, do you want me to come back to another MSB meeting once a conclusion has been reached, so you know that something actually happened, or what would suffice for you?
This is David. Thank you, Sarah, for asking that question. I think that's incredibly insightful and I appreciate it. Recognizing that fraud, abuse, and waste is a national dialogue, and obviously things that are pushing a lot of ideological decision making. I think coming back to this board and being able to say, hey, we have definitively determined that there was or abuse or waste, like, so that just coming back and closing that out, or even a letter or just something that says we as the state of Colorado are on top of this, we recognized it, we have completion. Like, that would just be great to know something was completed.
Okay, I will make sure that I let you all know that it's been completed and what the outcome is, and what the department chose to do.
Thank you, Sarah Caslow, who was speaking.
You're welcome, Sarah Caslow. This is Sarah Caslow speaking. The next time I will be much more, I will know all the different rules. So this is my first one. So thank you for being respectful and giving me a little bit of a break on that one. So
hi, Sarah. This is Laura Carroll, the president of the Medical Services Board. I also wanted to let you know that Chris Sykes, our administrator, is the absolutely positively best person to not only keep in contact with about the process, but I bet he could help you figure out the best way to get that information to us. That is what we have him here for and why we love him. So as that comes through, if you would please share that information through to Mr. Sykes, and he'll make sure that we get that information.
This is Sarah Caslow speaking. Yes, Madam Chairman, I will do that.
I appreciate it. Thank you, Sarah.
Thank
Do we
you.
have any other questions from the board? Let's see. Let's go with Dr. Kennard first.
Dr. Kennard here. First of all, good conversation. I think I've got an answer to JK's question, why an emergency? Emergency is $3 million going out this month and next month and next month and next month. So if we wait for 5 months to do the rule process. So I'm gonna, as soon as you give me a chance, I'm gonna make that motion. But at the same time, it strikes me that the maybe the end of this is not even just a report, but a well thought out rule. Because for all I know, the rule could be 4 times. There could be nobody orders this comprehensive panel without going through big hoops. So I don't know, 60 is just stopping this triage. And that's what we're doing today. And it's going to save us 15 million in the next, before the end of the year. So I'll support it for that reason, but I'd like to see foreclosure on a real rule. I thought of stakeholder engagement, investigation, but okay, can't wait to meet them.
Appreciate it. Sarah, did you have a response to that?
This is Sarah Caslow speaking. Yes, and I just wanted to touch too on that. We are doing stakeholder engagement. I worked with the stakeholder engagement team, and I recorded a video, or they recorded a video of the new limitations and restrictions, and just kind of what the department's proposing. And it'll be in the November bulletin, and then I've also sent it out to providers and different departments within healthcare policy and financing, have also sent it to different providers. And then there is a spreadsheet that the department has created that, that's where the feedback is shared. And so if it's helpful, I can provide, feedback to you all as well when we get it.
Thank you, Sarah. Rachel, I see your hand. Me, who you?
This is Rachel Andrikin with the department. One thing I did want to clarify, I should turn that off. It's really loud.
Pausing for 1 second to deal with some background sound.
I think it's the coffee pot.
Oh, it's icing.
Making ice. It's temporarily paused.
Great, thank you. It's really distracting.
I apologize, Rachel. Give it a shot.
All right, thank you so much. No, it's great. This is Rachel Andrikin with the department. One thing I did just want to make clear for all of our board members, emergency rules are not permanent. Emergency rules are only in effect for 120 days, and then they expire unless we separately run a permanent rule. So I did just want to clarify that for the board, so that, you understand that there's never an emergency rule that goes into effect and stays in effect forever.
No, and all of us who survived the COVID rulemaking extravaganza, there were stuff we were just approving and approving and approving and approving. So thank you for that reminder. It was like it was just yesterday, but also like a decade ago.
Absolutely, Madam President. Thank you.
Thank you, Dr. Costello.
Ms. Caslow, appreciate also that you've looked at other states and that the criteria, at least I'm told, in your opinion, meets criteria for emergency rulemaking. The substance of the rule, I actually would like to see it go further and have less presumptive drug testing. Having worked with dozens of addiction physicians, most of these are done in clinical settings. I think most are done reflexively. Like they move directly to definitive testing and don't use a point of care test. So there's very little clinical value. ASAM, American Society of Addiction Medicine, says definitive testing should really only be utilized after point of care testing and denial by the client. So essentially they do point of care testing that's cheap. They have a positive result. The client denies use, which we're getting pretty far down. A whole lot of people when presented with evidence of use say, oh yeah, you got me. And it doesn't change clinical decision-making. So definitive testing is really intended to be a rare occasion. And the only thing I can think of that mandates it is OTPs, so methadone clinics, have to do 8 per year. So that's really the minimum in my opinion. But I see no reason why we would be much above that, maybe 12 once a month.
Yes.
And I don't understand why youth should be exempted from this either. I don't think that's a big driver of costs, but I would like to see us go further and be across the board 12 for everyone. And that would save an additional, I don't know exactly how much, but it's colossal amount.
Thank you, Dr. Costello. Sarah, did you want to respond to that? You're on mute, Sarah.
This is Sarah Cathlo speaking. Thank you very much for your input, and I will take the limit, and I assume you're speaking of a limitation of 12 over 16.
Correct.
Okay, all right. I will take that back and to the department, see if that is, 12 is can be utilized over 16. And just to give you a little bit of when we first started working on this, the initial, what we originally wanted to do was put PARs on the codes. But when working with the utilization management team, and then also the vendor Centra, who does the PARs, the cost and was just astronomical, and the Centra wasn't able to handle that amount of PARs. So that's why we kind of went with the 16 limit. But I will take back the 12, and then I will get back to you on that as well.
1 second. That was Sarah. I just wanted to point out our acronyms real quick too. A prior, if I say this right, is a prior authorization review request.
Yeah.
So PAR is a prior authorization request. Thank you very much, Dr. Costello. Did you need to continue on?
One more thing. Thanks, Ms. Caswell. I did note that technicality about the vendor, and thank you for taking the 12 back. I think to enlighten other folks further, a lot of these aren't even driven by physicians and their patients. They're driven by sober livings who are not clinicians, they're not physicians, and they're reflexively doing weekly testing for people who are more or less a captive audience. And so I just want to give more context around where a lot of this volume is driven.
Thank you, Dr. Costello. I'm getting the feeling Dr. Mulkey has feelings.
Good deal. Is it my turn?
It is your turn.
All right, so my name is Christina Mulkey, and I am a stakeholder who is actually treating these patients, boots on the ground every day. So I'm going to speak from that perspective to not contradict Bill, but to tell you that I do this. I don't order this kind of testing that she's referring to per se, but I treat clients with substance use disorder and pain management, chronic pain management every single day, and I have to drug screen them. So if you shackle us in primary care too much so that we can't perform the testing, you will then restrict our ability to prescribe for the patients because we don't feel that it's safe, okay? First of all. Second, though, I do agree with this rule. I will be supporting it, and there needs to be limitations. And a lot of the issues are not with a doctor who's doing this or a nurse practitioner who's treating people in real life in the office. It's with these other locations that are misusing and overusing. Okay, so that we do have to have limits. So I do support this. 16, I agree with. Even 12, I would agree with. Going less than 12, I may not be able to support, just because, like I said, I see these people in my office and I have to test them. I can tell you many stories of how the definitive testing portion of it, which is only a reflex, if they're positive, then they do further testing. So I'm not ordering these crazy weekly, we definitively test everything BS that they're talking about, frankly, but the ones that we do when they definitively test, I have had clients who have been using fentanyl, who've stopped using fentanyl, and it's taken over 30 days to get out of their system. But I have drug levels, which comes from some of this definitive testing that proves that it's getting out of their system. So it's really, they're very interesting patients. They're not every single day, and they're not even every single month. So the levels of testing they're suggesting are okay. But if you do remove it completely, like you said, that's not going to be able to work, right? We're not going to be able to treat people successfully. So some drug testing is necessary for pain management and for substance use disorder treatment, but it should be coming from legitimate providers who know how to do this kind of treatment and who are using those drug tests to safely treat people, not some of the other scenarios that have been brought up today. So that's my perspective. I do support this. Like I said, I would even support going down to 12, less than 12. I couldn't support, but sounds like there's a lot of other issues going on here that really are not what needs to make primary care. But I do drug screen patients on Medicaid, and we do get confirmations, is what I call them. But there are confirmations done if they pop positive for something, because knowing what substance they're actually doing and having numbers as well, levels assigned to that, is really helpful for us. So that's my perspective.
Thank you, Dr. Mulkey. Did you have a response, Sarah?
Yes, this is Sarah Caswell talking. Thank you so much. I really appreciate your input and your recommendation. And, you know, kind of like you said, the majority of providers and are not abusing, you know, or utilizing the codes. And it's 20. And so, yeah, I really appreciate your input. And thank you so much.
Thank you, Sarah. Do we have any other questions from the board? Ooh, here we go. Do we have any public testimony signed up for rule number 8, Mr. Sykes?
This is Chris Sykes. Sorry, just flipping through. We do not have anybody signed up for public testimony on Rule 8.
All righty. Dr. Kennard, I'll accept a motion on this rule.
Thank you, Madam Chair. I move the emergency adoption of document 8 MSB 25-8-26-A, revision to the Medical Assistance Act rule concerning definitive drug testing, section 8.660, incorporating the statement of basis and purpose and specific statutory authority contained in the minutes.
Thank you, sir. May I have a second?
I have a point of clarification. Can I ask?
I have a point of order request from Dr. Costello.
Does adoption of this rule, this is Dr. Costello, this adoption of this rule preclude moving to 12 instead of 16?
Jennifer Weaver, no, this is just emergency adoption and this will come back for permanent rulemaking and there could be revisions.
But the emergency rule would be as
The 16.
written.
Which is in effect for 120 days.
Yes. Sorry, this is Chris Sykes. At the 120th day, if no action is taken, right? I mean, if the rule that comes back is at 12, the rule as it's written just drops off and goes away.
Did that answer your question, Dr.
Yes, it did.
Costello? Ms. Weaver, is it okay if I just ask for a second straight from here? May I have a second, please?
This is David, I'll second.
I will accept all the seconds. All in favor, please say aye.
Aye.
Opposed? Abstentions? Thank you, team. We have gotten through document 8. All righty, and onward to document 10. And it looks like I have Tracy Gonzalez with us this morning. Good morning, Tracy.
Good morning, Madam President. I will wait for the presentation to come up. Okay, here we go. Good morning, Madam President and members of the board. My name is Tracy Gonzalez. I'm the Finance Unit Administrator in the Special Financing Division. Today I'll be presenting MSB 25-07-24-A, Emergency Rule for the Provider Stabilization Fund. I am joined by Shannon Huska, the Special Financing Deputy Division Director, to assist with any questions. Next slide, please. Senate Bill 25-290, signed on May 28, 2025, created the Provider Stabilization Fund. The bill intends to provide much-needed short-term stabilization funding to eligible safety net providers that serve low-income uninsured patients and to help alleviate some of the financial stress caused by the Medicaid unwind and the increasing rate of uninsured individuals across the state. Next slide, please. There are four provider types that are eligible to apply for support under the Provider Stabilization Fund. They are comprehensive community behavioral health providers, rural health clinics, federally qualified health centers, and healthcare providers delivering primary care services with at least 50% of their caseload consisting of individuals enrolled in Medicaid, Medicare, Children's Basic Health Plan Plus, or individuals who are low income and uninsured. Next slide, please. To qualify for funding, providers must meet one of the eligible safety net provider conditions, complete an intent to participate, and submit a completed Provider Stabilization Fund application or an attestation form if they're using their primary care fund application. Next slide, please. Funding will be allocated to agencies based on the number of eligible patients seen during the calendar year. An eligible patient is a low-income, uninsured individual whose family household is at or below 200% of the federal poverty guidelines, who are not enrolled in Medicaid, Medicare, or Children's Basic Health Plan Plus, and who have no third party paying or reimbursing the provider for all or a portion of the amount charged for services. Next slide, please. The Provider Stabilization Fund consists of money credited to the fund from Unclaimed Property Trust Fund, as well as gifts, grants, and donations that may be received from the public or private sectors. Payments shall be based on an individual safety net provider's number of eligible patients in the amount proportional to the total number of eligible patients served by all safety net providers. Next slide, please. The bill required the governor to appoint an advisory board to support the department with the implementation of the Provider Stabilization Fund. The board was appointed on August 1st, and we moved quickly to get the process started. We held 3 advisory board meetings during August and September and worked with the advisory board to create the proposed rules being presented today. In your packet, you will find a letter of support from the advisory board. We bring this before you as an emergency rule because, as you know, safety net providers across Colorado shoulder significant costs in serving the low-income uninsured population and individuals and families enrolled in Medicaid and Children's Basic Health Plan Plus. We are eager to distribute funding promptly, to withhold the intent of the bill, and provide timely relief to these essential providers. Thank you for your time and consideration. At this point, I would be happy to answer any questions that you might have.
Thank you, Tracy. Do we have any questions from the board? Go ahead.
Hi, Madam Chair. This is Cassie Littler speaking, and thank you for your presentation. I have a couple of questions. My first is in the rule. I wondered where the definition of primary care came from.
Tracy?
Yes, this is Tracy speaking, and I think we have Shannon Huska on. If I could divert that to Shannon.
Good morning, Shannon. I see you.
Good morning. Thank you, Madam President. The definition of primary care came from consultation with the board, as well as referencing the current primary care fund program. It's a little bit of a hybrid, as this bill does not match 100% to primary care fund.
Thank you. This is Cassie Littler speaking. I think there's other primary care definitions in statute, I believe, that you may want to align with or alignment across rules. I'm not sure if that's a point of clarification or something that you want to take back or change, because it just seems a little unclear as to who a primary care provider is in this particular role.
Thank you. Tracy? Go ahead, Tracy. Or
This
is
is
it Shannon?
Shannon.
I'm sorry.
Thank you. And I'm looking for a point of order from Chris or someone. We can definitely take that back for further when we come back for final adoption.
I believe this is an emergency rule point
Right.
of order. I would have to confirm. So Mr. Sykes, we wouldn't have a second reading on this. We would just have once the final rule comes through, if it does in that 120 days. Is that correct?
This is Chris Sykes. So the emergency rule under the Administrative Procedures Act, right? You are correct, doesn't follow any formal rulemaking process, right? It's an emergency, you adopt it. Now, when the rule authors want to bring it back, right, they need to bring it back within 120 days so that there's no cliff drop off. Yes, that rule can be changed, much like the definitive drug testing, right? That is something they could take under advisement. Yes.
Thank you, Mr. Sykes. This is Laura Carroll, and in my experience, Cassie, they do that regularly. It is not unusual that by the time an emergency rule becomes the actual real rule, that's when they do all of the stakeholder data and all of that kind of stuff when the rule becomes permanent. I think by its nature, because the rule lacks permanence, and I don't think you're wrong, I think you're right, but I think that's how that happens, is because they're emergency rules. And I think it's a good comment for us to have going forward, for sure.
Thank you. This is Cassie Littler speaking. I guess my question is if we're sending out a bunch of money to safety net providers, but we don't have a clear, rule that says what primary care is. It just says they cover a range of prevention, wellness, and treatment for common illnesses, include doctors, nurses, nurse practitioners, physician assistants. They often maintain long-term relationships with patients and treat a range of health-related issues. They may coordinate with specialists. It just seems like who is primary care? Who are the safety net providers that provide primary care? So if money's being sent out prior to a permanent rule, then that's a bit of a concern.
Did you have a response to that, Shannon, or did Tracy? Either one.
Yes, Madam Chair, this is Shannon Huska. I understand what you are saying, and I will say that this definition took many iterations with the board itself and to come to a conclusion. Because the way this bill is written, it is so broad, but the parameters that make a primary care provider eligible is where we will see that difference of who is a primary care provider and not, because of having to reach 50% of Medicare, Medicaid, CHIP, or uninsured. It is a very broad definition, but that's a factor of the bill itself.
Thank you, Shannon. Does that answer your question, Cassie?
This is Cassie. Yes, thank you.
Wonderful. Dr. Costello?
Yes, thanks, Madam Chair.
You bet.
Ms. Gonzalez, this is Jacob Costello. I had a question on provider type comprehensive community behavioral health provider. I'm used to this, the new term being comprehensive safety net provider, because there is a federal definition of certified community behavioral health clinic, CCBHC, and I wanted to ensure that this is aligned with Colorado's comprehensive safety net provider type, which is a Medicaid provider type. I think it's 64.
Thank you, Dr. Costello. Did I have a response from the department?
Yes, this is Shannon Huska. Thank you, Madam Chair. Yes, we did align. If you see in the rule, we aligned it with the federal reference.
With the federal reference, not the state.
State reference. I'm sorry. I apologize. State reference.
Does that answer your question, Dr. Costello?
That does. I have one follow-up.
Please do.
Ms. Huska or Ms. Gonzalez, is there any requirement that these providers be nonprofits?
This is Shannon Huska. Thank you for the question. There is no requirement that they're nonprofits.
Okay. Thank you.
Cassie, I see your hand again.
Hi, this is Cassie Littler speaking. I see that the disbursement is once in a fiscal year, state fiscal year. I am wondering about changes that may come down where patients who may be on Coverall Coloradans and have Medicaid currently, but then may fall off of Medicaid in large numbers, particularly children as well, and is what I'm interested in, but also pregnant people. If that happens, will there be any sort of way that safety net providers could reattest to show that they have large increases in uninsured patients that have fallen off of Coverall Colorado Medicaid? as to avoid a PHE unwind situation.
We don't want any more unwinds. Thank you, Cassie. Do we have a response from the department?
Yes, thank you, Madam Chair. This is Shannon Huska. Yes, so the current year's application will use calendar year 2024's information. So as their uninsured patient load changes from year to year, they'll redo their application each year. So next year, they'll be doing it for 2026-27 fiscal year, they'll be submitting an application on calendar year 2025. So each year they have a chance to update their numbers to show those changes.
Thank you, Shannon. Did that answer your question?
Thank you. This is Cassie Littler. I think that answers the question as to how it's written, but I wondered if there was any, discussion about if there's dramatic changes in a fiscal year, if there would be an opportunity to attest it at a different time, or just thinking about some other options in disbursement of funding. Maybe taking back for a final rule.
Okay. Do we have a response from the department?
Yes, thank you, Madam Chair. This is Shannon Huska. We can definitely take that back to the board and look into it. But as I said, currently it's using a prior year's information. So we'll look into it though.
Thank you. This is Cassie Littler speaking again. I just, many pediatricians, there's, I think, like 20,000 children on Medicaid, right? From Coverall, Colorado. And if that were to drop off in 1 year, and you aren't getting Medicaid, right, payments, but you have to wait a full year for safety net stabilization funding, that's could be really difficult.
Thank you, Cassie. Do we have any other questions from Dr. Costello?
I have one more question.
You bet.
Thanks, Madam Chair. For Ms. Huska. In addition to comprehensive safety net providers and behavioral health, there's also a designation called essential that I know was left off. Although the word essential implies that they're very important. And I was wondering why they were left off. They tend to be smaller, less capitalized providers who would be more subject to the buffeting winds of uncertainty versus the comprehensive providers. So could you tell me why essential providers are not included?
Madam Chair, this is Shannon Huska. I believe that those essential providers are captured in the healthcare provider that meets the 50% requirement. So there's 3 ways that a provider automatically qualifies, and that is if you're a behavioral health provider, a rural health clinic, or an FQHC. But if you're not one of those, then you qualify under the healthcare provider who sees at a minimum 50% of Medicare, Medicaid, Child Health Plan Plus, or uninsured. And that's where everyone else would fall.
Thank you, Shannon. This is Laura, President of the Medical Services Board. As a point of order, can you please call out your acronym FQHC?
Yes, I apologize, Madam Chair. FQHC is Federally Qualified Health Center.
Thank you very much. I appreciate it. Dr. Costello, does that answer your question? I see you are reading over the rule, which I love.
Thanks, Madam Chair. I don't see that, but the verbal answer does answer my question. So I'll keep reading through the rule.
Very good. And I'm sure that Mr. Sykes would be happy to connect you, Dr. Costello, with Shannon if you guys wanted to kind of look it over and work through it together. Is that correct, Mr. Sykes?
This is Chris Sykes. Yes.
Would that be helpful to you, Dr. Costello?
Yes.
Fantastic. May I continue? May I see if there's any other questions? Are you all set? Fantastic. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony today?
This is Chris Sykes. We do not have anybody signed up for public testimony on Rule 10.
Wonderful. Then I will accept a motion on document 10.
Barry Martin, I can take it.
Dr. Martin, it's yours.
Move the emergency adoption of document 10 MSB 25-07-24-A. Creation Medical Assistance Act rule concerning the Provider Stabilization Fund program, section 8.970, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second, please?
This is Cassie Littler. I second.
Thank you, Dr. Littler. All in favor, please say aye.
Aye.
All opposed? Abstentions? Wonderful. Document 10 passes and we are in recess for 5 minutes.
There you go. We're back.
Hello, thank you. Welcome back. I want to make an official call out to our IT guy Kelly, working with us down in Denver. You make us look good every single day. Thank you.
And we miss you here.
And we miss you. You're supposed to come with us to this stuff. All righty, we are now on to final adoption by consent. Do we have anything that we feel needs to come off consent agenda today? Hearing none. With that, I would accept a motion for final adoption by consent. Want me to do it? I would love that, Dr. Mulkey. Thank you.
I move the final adoption of document 1, MSB 25-06-04-A, revision to the Medical Assistance Act rule concerning SB 25-084, Medicaid access to parenteral nutrition implementation, sections 8.800.A and 8.800.13, incorporating the statement of basis and purpose and specific statutory authority contained in the. And I move the final adoption of document 2, MSB 25-04-22-A, revision to the programs of all-inclusive care for the elderly, PACE, section 8.497, incorporating the statement of basis and purpose and specific statutory authority contained in the records. And I move the final adoption of document 3, MSB 25-04-02-B, repeal of in-home support services and transition services, sections 8.552 and 8.553, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Mulkey. May I have a second, please?
I'll second.
Thank you, Dr. Costello. All in favor, please say aye. Aye. All opposed? Abstentions? Wonderful. Final adoption by consent agenda is done. We are on to the final adoption portion of the program. First up is document 4 with our friend Taryn. Good morning, Taryn.
Good morning. Good morning, Madam President, members of the board. My name is Taryn Graff, and I am the State Programs Work Lead in the Special Financing Division. Today, I will be presenting the MSB 25-07-08-A, revision to the Hospital Discounted Care Rule concerning presumptive eligibility per Senate Bill 24-116. Hospital discounted care sets the minimum standards for hospital financial assistance for all general, acute, and critical access hospitals throughout the state, and is available to patients who are determined to be at or below 250% of the federal poverty guidelines. Patients who are current Health First Colorado or Child Health Plan Plus members are not eligible for hospital discounted care. The law requires that hospitals screen all uninsured patients for eligibility for hospital discounted care, Health First Colorado, the Child Health Plan Plus, and Medicare, and it requires hospitals to also screen any insured patients who request financial assistance. It includes protections on what patients may be billed, when patients can be sent to collections, and also limits payment plans to no more than 36 months of payments. The monthly payments for created payment plans can be set to no more than 4% of the household's calculated gross monthly income on a bill from a hospital, no more than 2% of the household's calculated gross monthly income on a bill from a physician, and no more than 6% of the household's calculated gross monthly income on a bill that contains both hospital and physician charges. Senate Bill 24-116 passed in the 2024 legislative session, and the majority of the changes directed by the bill were brought to the December 2024 Medical Services Board meeting and became effective in March 2025. This last part of 24-116 had to be held back to align with updates to the populations covered under Health First Colorado's presumptive eligibility process, which is what is covered in another rule change that will be presented today by Daisy Martinez. My rule this morning relates to adding the ability for hospitals that are required to follow hospital discounted care to voluntarily elect to become presumptive eligibility sites to check uninsured patients for presumptive eligibility in tandem with completing the required screening under hospital discounted care. Under current rules, hospitals are not allowed to deny a patient eligibility under hospital discounted care based on whether the patient has applied for public benefit programs. Senate Bill 24-116 added an exception to this mandate that allows hospitals to deny discounted care if, during the initial screening process, the patient is determined to be presumptively eligible for Health First Colorado or CHIP Plus. Language related to this change is included on page 4, lines 23 through 28, and page 9, lines 2 and 3 in your packets. You will see that the changes included on page 4 have been highlighted as additional changes were made since the last meeting. Daisy's rule that I mentioned earlier contains a definition of qualified hospital presumptive eligibility site, so my rule has been updated to point to her definition. Any hospital that has been certified by the department to be a qualified hospital presumptive eligibility site will be allowed to deny discounted care for patients who are determined to be presumptively eligible for Health First Colorado and or CHIP Plus, prior to allowing them to apply for hospital discounted care. The rule makes it very clear that hospitals may not complete a presumptive eligibility screening in lieu of completing the hospital discounted care screening, and that it is the hospital that would need to be the entity making the presumptive eligibility determination. This ensures that the hospital discounted care screening process continues to be completed by the hospital as required, and that uninsured patients are not being sent to other sites for presumptive eligibility determinations. At the last meeting, the board had a question related specifically to patients who may be eligible for Cover All Coloradans, but was more broadly about patients who do not want to apply for Health First Colorado or CHIP Plus due to concerns about their immigration status and providing their information to the state agency. Our team worked with various colleagues, including Rachel Entrekin and Adela Flores-Brennan, over the last month to get an answer for this question. It has been determined that Cover All Coloradans does fall under the definition of state medical assistance plan, and it is a program that PE sites, presumptive eligibility sites, are allowed to use presumptive eligibility for. However, patients must give their permission for a presumptive eligibility site to complete that eligibility for them. So my team believes that we have the ability within policy to allow for patients to choose not to do the presumptive eligibility screening while still being allowed to complete the screening for hospital discounted care. Additionally, if a patient does complete a presumptive eligibility screening and is determined eligible, the statute states that the hospital may deny eligibility for hospital discounted care, not that they must. We will ensure it is clear in policy that hospitals are encouraged to take immigration concerns into account when screening patients and determining whether presumptive eligibility patients are allowed to apply for hospital discounted care. Thank you for your time this morning. I'm happy to take any questions you may have on these changes.
Thank you, Taryn. Do I have any questions from the board? Very good. Mr. Sykes, do I have anyone signed up for public testimony today?
This is Chris Sykes. We do not have anybody signed up for public testimony on document 4.
Wonderful. Then I will accept a motion for document 4.
Do that motion.
Thank you, Cassie. Go ahead.
It's Cassie Littler. I move the final adoption of document 4, MSB 25-07-08-A, revision to the hospital discounted care rule concerning presumptive eligibility per SB 24-116, incorporating the statement of basis and purpose and specific statutory authority contained.
Thank you, Cassie. May I have a second, please?
Also,
It's
Thank
David,
you,
I
Dr.
second.
Costello. I got Dr. Costello first on that one, David, but thank you. All in favor, please say aye. Aye. All opposed? Abstaining? Very good. Document 4 passes. On to document 5 and Melissa Escamilla.
Good morning, Madam President and board members. Thank you for your time today. My name is Melissa Escamilla, and I am the Eligibility Policy Supervisor here at the Department of Healthcare Policy and Financing. I am here to present MSB 25-05-30-A concerning updates to continuous eligibility rules. I'm here to present rule updates concerning the Modified Adjusted Gross Income, also known as MAGI Medical Assistance Programs, regarding children's continuous eligibility, which I will refer to as CE. For members who are eligible and enrolled in Medicaid, the children's continuous eligibility updates apply to all children defined under 42 Code of Federal Regulations, 435, Section 435.926B. The proposed rule changes will amend Section 8.100.3.Q.2. Lowercase d. This policy change aims to expand coverage in accordance with Section 5112 of the Consolidated Appropriations Act of 2023. This amended titles 19 and 21 of the Social Security Act. These policy changes also stem from the state health official letters 23-004 and 25-001 received from the Centers for Medicare and Medicaid Services, which provides states with information on implementing CE requirements under the Consolidated Appropriations Act 2023 amendments. This implementation requirements guide states in improving enrollment practices for states that provide children with a full 12 months of continuous eligibility coverage. This includes maintaining eligibility regardless of any changes in circumstances, with a few exceptions. These changes also apply to children under 19 enrolled under the state plan in a mandatory or optional Medicaid eligibility group. While Colorado already provides children enrolled in Medicaid with 12 months of CE coverage, we found that specific updates are needed to prevent the disenrollment of CE children due to the failure to pay monthly premiums during a CE period. Updates were required systematically and within policy to ensure full compliance with the implementation guidelines set forth by the Centers for Medicare and Medicaid Services. These proposed rule updates to continuous eligibility align the state with those guidelines. These updates require us to update our rules to remove the disenrollment process for children or youth enrolled in either the Working Adults with Disabilities and Children with Disabilities buy-in programs who fail to pay their monthly premiums once their CE period begins. While these members may remain enrolled due to non-payment of their buy-in premiums, they will still receive bills for both current and overdue premiums during the CE period. This policy change will also be updated in our Colorado Benefits Management System, also known as CBMS, to align policy and eligibility. In response to questions from our previous MSB meeting, we want to provide an update to board members. As of today, there are a total of 481,601 children enrolled in programs, Medicaid programs today. This excludes our CHIP population, with only 2,294 of those children participating in our buy-in programs. This accounts for less than 1% of our Medicaid enrolled children or child population. Since we reinstated premiums in May of 2025, we do not yet have a full year of analysis. However, we do know that from May 2025, when premiums were restored, 399 children from the buy-in programs have been disenrolled from July through October due to failure to pay their monthly premiums. it's important to note that disenrollment started in July because we allow a full 60-day grace period for members to pay their premiums before disenrollment. We have determined that the average monthly enrollment fee for members disenrolled for non-payment was $63. So, for example, if a member chose to not pay their premiums for an entire year, the total cost would be $693 annually. If we consider keeping those who were enrolled or disenrolled, those who were disenrolled between July and October enrolled, assuming they didn't pay any premiums for the entire year, this would lead to an estimated total of $276,507 of non-paid premiums for the year. Now, this calculation represents a worst case scenario in which no one pays their premiums over the full year. To help recover these unpaid premiums, we will still continue, as stated before, to send premium letters to both current and overdue premiums during the member's entirety eligibility period. Now, to keep in mind, we are implementing these updates to ensure compliance with federal requirements regarding the implementation standards set forth by the Centers for Medicare and Medicaid Services, and to align our policy with Section 5112 of the Consolidated Appropriations Act 2023. Continuous eligibility is a mandatory program and not optional. According to federal guidance, children enrolled in Medicaid who are entitled to continuous eligibility can only be disenrolled from medical assistance under specific exceptions. Disenrollment due to the failure to pay in monthly premiums is not an exception to the continuous eligibility requirements. Therefore, we must keep these children enrolled. By implementing these changes, we're improving continuous eligibility coverage for members who are eligible and enrolled in Medicaid. In addition, providing continuous medical assistance to eligible members, regardless of changes in their circumstances, such as non-payment of buy-in premiums, aims to ensure that children and youth remain enrolled in medical assistance. This will enable members to continue receiving essential health care, ultimately leading to healthier Medicaid-eligible members. Now, to summarize the updates to the rules under Section 8.100.3.Q, point 2, lowercase d, we have clarified the language regarding the 2 buy-in programs available for children and youth. The subparagraph I was modified to state that members enrolled in these programs will not have their enrollment discontinued due to the failure to pay premiums. However, they will still receive monthly statements reflecting any outstanding balances. Additionally, the department has not received any additional feedback or questions from member advocates, county workers, or other stakeholders regarding these continuous eligibility policy updates, and the Attorney General had no further suggested changes and has approved the rules as written. In conclusion, these rules updates are relatively minor, but the department believes that they will positively enhance our continuous eligibility policies for children and youth, and I appreciate everyone taking the time to hear our request today. Are there any questions that I can answer for you?
Thank you, Melissa. Do I have any questions from the board?
This is Barry Martin. I have a question or a couple of questions.
Dr.
actually.
Martin?
One is, I often wonder in programs like this where the premium amounts are relatively low, whether we spend more on trying to collect the premiums than we actually collect, and is it worth the time and effort of trying to do this? And then the other question I have is, if people don't pay their premiums, will it affect their credit rating? I'm assuming they're not sent to collections.
This is Melissa Escamilla responding, and thank you. That's a good question, Barry. I would say one, that no, this does not affect somebody's credit. They do not get sent to collections for this. As for the cost, we looked at the cost of, say, we're sending these letters out every month. It would be the same cost as if they were still paying their premiums as well. We're still sending out that monthly premium statement. So whether they're paying it or not, it doesn't really change the cost of sending out that letter. As for other costs such as associated, which would be like the collections of the enrollment fees and so forth, we do have automated ways to do that, such as our Peak online system, where they can, where they usually do the applications online. That right there is a way to cut administrative costs because it's an automated system where people can just put their information in and make their payments. As for when it comes to like costs with our CMAP partner, our federal contracted partners that take the collections and updating this information, I don't have direct cost analyses on how much it would change, but I'm not seeing a projected difference in what they don't already do today.
Mary Martin, if I can ask just a follow-up question. So as far as you know, the net financial benefit of having people pay premiums for these programs is positive. We collect more revenue than we spend on trying to implement these programs.
I would say for the enrollment fee or the monthly premiums, that would be yes.
Okay.
That was Melissa Escamilla. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony today?
This is Chris Sykes. We do not have anybody signed up for testimony on document 5.
Very good. Then I will accept a motion on document 5.
I can do it.
Thank you, Dr. Mulkey.
I move the final adoption of document 5, MSB 25-05-30-A, revision to the Medical Assistance Act rule concerning updates to the continuous eligibility medical assistance programs for children under the age of 19 for sections 8.100.3.Q.2.D, incorporating a statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Mulkey. May I have a second, please?
Mary Martin, I'll second.
Thank you, Dr. Martin. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Wonderful. Document 5 passes. On to document 6 with Daisy Martinez. Good morning, Daisy.
Good morning. This is Daisy Martinez. Good morning. I am going to share my screen because I do have a PowerPoint. Okay, is it displaying my PowerPoint?
It is displaying it, however, in presenter mode. Or not in presentation mode. I don't know if you wanted all your other stuff on the screen with it.
Let's see if I can update that.
Let's just go with it.
I think that'll be fine. So, good morning, Madam President and board members. Thank you for your time today. My name is Daisy Martinez, and I am the Presumptive Eligibility Policy Specialist for the department. I will be presenting MSB 25 Tax 07, Tax 01, Tax C, and CHIP 25 Tax 07, Tax 01, Tax D, concerning updates to presumptive eligibility by qualified hospitals. I am here today to present rule updates concerning the Modified Adjusted Gross Income, which I will refer to as MAGI, and non-MAGI medical assistance programs, and the Child Health Plan Plus program, which I will refer to as CHIP Plus, regarding presumptive eligibility by applicants who are eligible for either medical assistance or CHIP Plus. This presentation will address the current PE processes, outline the proposed changes and expansions, and identify components included in the service costs. Specific modifications to MSB 25 Tax 05 Tax 07, Tax 01, Tax C, and CHIP 25, Tax 07, Tax 01D will also be reviewed. The medical assistance proposed rule changes with MSB 25 Tax 07, Tax 01 Tax C will amend sections 8.100.1 and 8.100.4.f and create a new section 8.100.3.r. The CHIP Plus proposed rule updates with CHIP 25 Tax 07 Tax 01 Tax D will amend sections 50 and 170. The presumptive eligibility, which I will refer to as PE, by qualified hospital updates apply to all applicants who meet the eligibility requirements of the PE groups defined under 42 Code of Federal Regulations, sections 435.1102, 435.1103, and 435.1110. The purpose of these policy changes are to expand coverage in accordance with Senate Bill 24 TAC 116 and Section 1902 A47B of the Social Security Act. These changes are based on the informational bulletin issued by the Center for Medicaid and CHIP Services. This bulletin provides states with guidance on implementing hospital PE as authorized by the Affordable Care Act. These implementation requirements guide states in expanding their coverage and enrollment practices for those offering PE. This includes allowing hospitals that have chosen to serve as PE sites to make determinations for PE in accordance with state policies. Additionally, these hospitals are encouraged to assist individuals in completing medical assistance applications and understanding the necessary documentation requirements. The proposed rule updates to PE are designed to align state policy with existing federal guidelines. Currently, there are a total of 23 PE sites. This includes 17 clinics, health centers, community centers, and 6 hospitals. These PE sites are currently authorized to make PE determinations for the following existing PE populations, which include children under 19, pregnant women, and those eligible for limited family planning. In addition, pregnant women and children under 19 who meet the Cover All Colorado criteria, such as being undocumented or a non-qualified non-citizen, can also apply for PE. PE sites are required to be recertified annually to continue to make PE determinations. As of today, the percentage of applicants that have applied and been approved for PE is 33%. Currently, PE sites agree to and sign a memorandum of understanding. Within this memorandum, PE sites are required to have a 95% accuracy rate for PE determinations in order to remain in a PE site and continue to make PE determinations. The following proposed rule updates are specific to MSB 25 Tax 07, Tax 01, Tax C. Qualified hospital PE sites are authorized to make PE determinations for individuals such as those who have an inpatient or outpatient hospital service and apply for most existing PE populations, which include children under 19, pregnant women, and those eligible for limited family planning. In addition, new rule changes will expand the number of authorized PE sites and the populations eligible for immediate and temporary benefits under PE. Qualified hospital PE sites will determine the PE status for the following expanded populations: adults aged 19 to 64 who appear to meet the MAGI adult eligibility criteria, parent or caretaker relatives who appear to meet the MAGI parent caretaker eligibility criteria, and applicants aged 16 and over who are employed, disabled, and appear to meet the Medicaid buy-in for working adults with disabilities eligibility criteria. If an applicant is deemed to meet the eligibility criteria for these 3 new populations, they will receive immediate and temporary Health First Colorado benefits, while a full determination on their medical assistance application is processed. During a PE period, providers will be able to temporarily bill for services that are provided to low-income members while they wait to have their application processed and a determination made by an eligibility site on whether they qualify for continuing medical assistance benefits. These three newly expanded PE populations will be available effective January 1st, 2026. With Senate Bill 24 TAC 116, hospitals have volunteered to become PE sites, will have the ability to make PE determinations for existing PE populations of children under 19, pregnant women, and those eligible for limited family planning, along with the three newly expanded populations. At this time, 23 hospitals have expressed interest in becoming PE sites, with 3 of those hospitals already certified as a PE site, and they will receive additional training to make PE determinations for the 3 newly expanded PE populations. The current PE sites that include clinics, health centers, and community centers will continue to make PE determinations for the existing PE populations and will not make PE determinations for the 3 newly expanded populations. Within Senate Bill 24 TAC 116, service costs will cover the enrollment and training needs of the hospitals who have expressed their interest in becoming PE sites, and will also include Medicaid coverage for patients determined to be presumptively eligible by hospitals. The following proposed rule updates will present in both MSB 25 TAC 07, TAC 01 TAC C, and CHIP 25 TAC 07, TAC 01 TAC D. Rule updates will include references to citizenship exceptions for pregnant women and children under 19. The recertification period for PE sites will change from 2 years to every year to remain approved as a PE site, and this is to align the department's current recertification processes. Additionally, we will revise the current language concerning appeals to clarify that applicants can appeal a county department's failure to act on an application or denial rather than the PE period, as the PE period is not subject to appeal under federal regulations. New rule language will also clarify the eligibility criteria for PE, specifying that applicants cannot be enrolled in another medical assistance program. PE can only be granted once every 12 months, with the exception for pregnant women who may receive PE once per pregnancy. We have identified the need for specific systemic and policy updates to ensure full compliance with the implementation guidelines established by the Centers for Medicare and Medicaid Services. And to reiterate, the department did not receive feedback or questions regarding the rule updates for PE by qualified hospitals from member advocates, county workers, or other stakeholders. Therefore, no additional policy changes were necessary. Allowing hospitals to make PE determinations and expanding PE will allow more individuals to be eligible under this category. This would increase the access sites to PE, which will help provide low-income individuals with immediate access to medical care while they wait for a full determination to be made on their medical assistance application. PE can help reduce the financial burden of healthcare costs for these individuals when seeking coverage for medical care. And then lastly, the department wants to acknowledge and thank the Attorney General's office for their suggestions provided to us for these policy changes. This will conclude our eligibility policy updates at this time. Are there any questions that I may answer?
Thank you, Daisy. This is Laura Carroll. I have to point of order myself. Daisy is presenting both documents 6 and 7 simultaneously. This is something that we tested out in the last meeting when we had mirroring rules between Medicaid and CHIP. And it was my mistake. I did not introduce it that way. And I want to make sure that we're staying transparent in what we're doing here. My apologies, my error. With that, do I have any questions from the board?
Just had a question. I don't know if you have the answer. This is Cassie Littler talking, sorry. You had mentioned that 33% of applicants get presumptive eligibility. And I just wondered if there's any information on how many are get the final determination of those applicants for Medicaid?
This is Daisy Martinez. So currently we don't have that information. I did try and get that data. It's a little difficult to obtain that data really quickly due to the different systems that go into play, because the environment that we use for PE determinations don't exactly connect with the ongoing system to make those final determinations. So we weren't able to collect that information. I think it's been about a month since we last met. But yeah, we weren't unfortunately able to get that information.
This is Cassie speaking. Thank you. No problem.
Mr. Pump, I see your hand.
Thank you, Madam Chair. This is David. Daisy, I ran a PE shop in the past, PE location in the past, and that conversion rate was exceedingly high from providing the PE to having a final determination and the way in which the PE went, because the PE location is filled with the correct data, getting the pieces put together. So I would be surprised if that has been reduced at any time. Just FYI.
Thank you, Mr. Pump. Did you have a response?
This is Daisy Martinez. Thank you so much. Yes, and just to reiterate, we do require a 95% accuracy rate from our PE sites. So the information that they are inputting into the system, that is getting verified that it is correct, and these determinations are being made correctly with the information that they do have on hand.
Thank you, Daisy. Does that answer your question, Mr. Pump?
Yeah, absolutely. More just of a statement. That's David. Thanks.
You bet. Any other questions from the board?
This is Cassie Littler. I just had one other question. You said that that presumptive eligibility can only be given once every 12 months or once per pregnancy. And I just wondered if there's a way for one hospital to know that there was presumptive eligibility at a different hospital within that 12-month timeline.
This is Daisy Martinez. Yes, it is a shared system, the system to make the PE determinations. So they can easily check to see if an individual did receive PE within the last 12 months. There is also a system stop to prevent authorizing PE for individuals who have had a PE period within the last 12 months, with the exception of pregnancy.
Excellent. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony for either documents 6 or 7?
This is Chris Sykes. We do not have anybody signed up for testimony on documents 6 or 7.
Wonderful. So first, I would accept a motion on document 6.
Chair, this is Cassie Littler. I can move for document 6.
I appreciate you, please.
I move the final adoption of document 6, MSB 25-07-01-C, revision to the Medical Assistance Act rule concerning presumptive eligibility by qualified hospitals, sections 8.100.1, 8.100.3.R, and 8.100.4.F, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Cassie. May I have a second, please?
Christina, second.
Thank you, Christina. All in favor, please say aye. Aye.
Aye.
All opposed? Abstentions? Wonderful. Document 6 passed. May I please have a motion on document 7?
This is Barry Martin. I can take it.
Thank you, Dr. Martin.
Move the final adoption of document 7, CHP 25-07-01-D, revision to the Medical Assistance Act rule concerning presumptive eligibility by qualified hospitals, sections 50 and 170, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is David, I second.
Thank you, Mr. Pump. All in favor, please say aye.
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 All opposed? Abstentions? Wonderful. Document 7 passes. Great job today, team. With that, I am bringing on a closing motion. I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. May I have a second, please?
Second.
Thank you, Dr. Costello. We are adjourned.
We're not adjourned.
We're done with our rules portion.
Yes.
Now, how are we looking on open forum, Chris?
This is Chris Sykes. We do not have anybody that had signed up for Rule 9 and public testimony online.
So are we going to take that as we have no public testimony today?
Both Kelly and I have reviewed, this is Chris Sykes, both Kelly and I have reviewed the participant list, and we're looking at the current testimony sign-up sheet. And there is nobody online that has signed up.
Well, unless I get a hand slapping by my legal department, I would dare call us in real adjournment, team. Well done. Thank you, everybody. Have a great month.
Thank you.